Thank you, Dr. Griep. I would like to extend my appreciation to invite me back again. I think I've been here every meeting since 1988. And as Nick said, it was just a little group of 50 or 100, 150 individuals in the early days. Look at what's happened now. I thank Dr. Landsman and the program committee for allowing me this opportunity. When I was assigned this topic, my first thought was, God, I'm getting old. What happened to the last 20 years? And it feels like it was yesterday when Mike Dake and I put in the first thoracic stent graft in July of 1992. Most of you know that was less than a year after Juan Perotti and Julio Palmas had done the first EVAR in Buenos Aires, which of course was after the unknown work in Russia. So as I thought about the topic, I thought I'd take you through the evolution of the field, and we're going to come full circle. Disclosures, nothing of which is relevant to thoracic stent grafting or TVAR, but it started back in July 1992, and believe it or not, in December of 1994, there was a paper published in a rather prestigious medical journal where we described our first results. The maternity is never in doubt, and you'll see Mike Dake on the left here when he was at Harvard College in 1973, along with Steve Osterly, who was an interventional cardiologist and now an executive vice president at Medtronic. Look at these two kids from Indiana, right off the farm at Harvard College. If you look closely at Mike with the yellow tie, I think you'll appreciate an uncanny resemblance to Andreas Grunzig in the 1970s. So maybe there's a gene mutation here that affected them both. And then 21 years later, look how these Harvard kids clean up, Mike and Steve. But Mike is certainly the mother of this concept, and he was the first intrepid, bold, pioneering person to convince me that this was at least semi-safe and reasonable in the case of a middle-aged man who had had a coarctation repaired 30 years previously and had a false aneurysm. So we owe Mike a great deal of credit. On the paternal side, who knows? I guess I'm guilty as charged, but Scott Mitchell is also guilty as charged. We have aided and abetted this criminal activity, if you will. And indeed, there is a role for stent grafting of the thoracic aorta, but what that role is needs to be more clearly defined if we are going to avoid abuse of neat new technology, either in those who should have an open operation, or perhaps more poignantly, in those who are too sick from too many infirmities where nothing should be done. This article in 1994, I am confident, will be the last uncontrolled retrospective observational study of 13 patients ever to be published in the New England Journal of Medicine. I can't believe how low they lowered their standards. But that was the start. A couple days later, a reporter from the Boston Globe called me. I think he had Marfan syndrome. He was very knowledgeable. And this appeared in the Boston Globe that month. I said then, we won't know until then, 4 or 5 years, if this is the smartest thing we've ever done or the dumbest. Now, 18 years later, I can ask that question with equal uncertainty about the answer. Nick Kachukas, in a fine review of thoracic aortic disease in 1997, actually gave this technology 2 sentences in a 6-page report. He said there might be a glimmer of hope that this technique can help patients who are too sick to operate on. In 1998, we thought we were on a roll. We presented our results at the ATS, and this was published in the Journal of Thoracic Cardiovascular Surgery in 1998, where we had 103 patients, and we thought we had worked out all the kinks of this new technology. how wrong we were. We showed that the program was building, but also as a corollary, the number of open graft replacement cases, as shown in gray, was also growing. This notion applies equally well to the percutaneous AVR field, where this actually will grow your overall volume, both open and endo or percutaneous. Survival was acceptable over the short term. 1 or 2 years is all we could talk about then. But you'll see the glimpse here that the 2/3 of patients that were deemed inoperable by Scott Mitchell or myself, as shown in red, did not fare as well as those who were suitable open operative candidates. This will become important. We espoused at that time strict definitions for treatment failure. This is one of the bugaboos of the whole field of TVAR. The SVS has definitions, STS has definitions, and everybody's talking a different language. We need strict, rigorous, and uniform definitions for our reporting, or we'll never be able to compare in a meaningful way reports from different centers, reports with different devices. I pirated this from Albert Starr, who came up with the concept of treatment failure pertaining to heart valve replacement, where he recognized that the trade-off between bleeding and thromboembolism could not be ignored. So you have to look at the overall picture. And an important point, which has lived on, is that we have to include all sudden, unexplained late deaths in the absence of an autopsy. This obviously will overestimate the incidence of treatment failure, but it levels the playing field since all of us have these cases and very few of us have universal autopsies. Treatment failure was a serious problem then, and it remains a serious problem today. The invited discussant was none other than our moderator and my mentor, Randall Greep. And if you wondered yesterday afternoon when I said some things that I'm not ashamed to have said, where I acquired this sense of cynicism and skepticism. Well, here was Dr. Greep's words. To summarize then, the stent graft does not work well on the proximal aorta because blah, blah, blah. And it also does not work well in chronic aneurysms because of the eccentricity of the lumen. Its placement is associated with a mortality and morbidity that is not dissimilar from that of surgical treatment. It may not treat the disease. What then is its role? Now you can see where I acquired that skepticism. Notwithstanding this tirade, I must state that I do believe that stenting will find a role in the treatment of thoracic aortic aneurysms. I don't think Dr. Greep in 1998 ever believed it would find the role that it has today. I thank Dr. Greep for his tirade, and I said since he was one of my teachers, I couldn't get too angry. The next step along the way was to expand the envelope of therapy for TVAR to other indications, including acute traumatic tear and acute complicated type B aortic dissections. This paper was published in 1999, again in an obscure medical journal, along with Chris Neinhauber's first report of stent grafting in subacute type B aortic dissection patients. We did our first acute complicated type B patient in 1996. Here we showed that the true lumen re-expanded, and most of these patients presented with malperfusion due to collapse of the true lumen, and a few had impending rupture or frank rupture. We all know what a dire situation this is, and then and today I personally believe TVAR will save more lives in the context of acute complicated type B dissection than it ever will for aneurysms or acute traumatic tears or other pathologies. This is truly a life-saving innovation, as has been reported by many of the members of the faculty here today and around the world. This was the first case in 1996. He had refractory hypertension, refractory pain, which today are known as soft indications. The FDA today will not let you enter a patient in an acute complicated type B trial with such indications. They only use hard indications, as we did in the physician-sponsored IDE trial 2 years ago. We put a short stent graft. These were the old Palmaz stents with an ironed-out, coolly, very soft graft sewn the night before, covered the primary intimal tear, but you'll see distally that there was a pronounced filling of the false lumen retrograde from a fenestration at the celiac axis. Therefore, we followed this with bare metal stenting, again, Palmaz stents of the true lumen, to prop open that true lumen. This is directly analogous to the currently available Cook TX2 dissection petticoat device. Well, we got lucky. 10 years later, this patient's thoracic aorta is completely normal, except for all the chicken wire in it, and he still is left with his Crawford Extent 4 chronic dissection thoracoabdominal aneurysm, which fortunately has remained stable. Philippe Demers, who's from Montreal, in 2004, took the same original 103 patients when we had a mean follow-up of 4.5 years and a maximum of 10. He looked at all survival versus the U.S. Population matched for age and sex, and it wasn't near as good as the general population, but it wasn't unrespectable with regard to open surgical descent and aortic repair. However, when you looked at the two-thirds, where Scott and I had deemed them inoperable, you can see a dismal, soberingly poor 36 and 60-month survival, with only about 30% being alive 5 years later. This led us to publish this quote, which has been widely ignored. Can you imagine what it took to get Mike Dake to sign onto this paper when we put this language in? Let me read quickly. We cannot definitively answer the philosophical question each individual physician must address and the ethical question society must face concerning whether stent grafting should be withheld in elderly patients with asymptomatic aneurysms who are not open operative candidates. Well, the majority of patients today receiving a TEVAR fit that bill. The soberingly dismal life expectancy in patients not judged suitable for open surgical repair is a direct reflection of patient selection criteria. What we do know is that stent grafting in asymptomatic patients does not improve quality of life. Indeed, a cynic would term this futile therapy and submit that preventing aneurysm rupture by stent grafting only prolongs patient suffering due to their multiple other debilitating medical diseases. Just because we can treat does not necessarily mean we should treat. Despite that warning, in 2005, the FDA approved the GORTAG device for chronic aneurysms in the United States, and Mike Dake and Barry Katzen wrote this glowing review for Circulation, and thereafter it was Katie bar the door, as you all know. In 2010, a rigorous meta-analysis sponsored by the EACTS in Europe was published in JACC by David Cheng and others. Here we began to see the first rigorous clue of what stent grafting really could accomplish. If you looked at 30-day mortality, as shown on the bottom with all these published series, there was a survival advantage to TEVAR over open surgery. But at 1 year, that statistical advantage was lost, and at 2 to 3 years, it was completely eliminated. The final nail on the coffin, if you will, regarding inappropriate use or abuse of TEVAR came out last December in Circulation. This is a U.S. Medicare analysis by Goodney, Travis, Lucas, Fillinger, Goodman, Jack Cronenwit, and David Stone from Dartmouth. They looked at Medicare physician supplier file data from 1998 to 2007. You had to have been a Medicare beneficiary for at least 1 year so they could capture all the comorbidities. 15,000 patients, excluding dissections, were analyzed, both intact and ruptured. And you can see the numbers here. The majority were done with open surgical graft replacement. Absolute verified vital status was determined by the Medicare denominator file. This is a problem with all of our clinical research studies, is that we don't have a financially feasible current way to do a body count for all of our therapies. But in this case, they knew the vital status of each and every patient with certainty. They looked at unadjusted 5-year survival, adjusted survival for age, sex, race, era, and Charlson comorbidity score. The limitation of this study is, of course, it's an administrative database. It's not a clinical research database. And finally, they did propensity score matching for 550 pairs, looking at the lowest risk quartile by age, sex, race, year, comorbidity score. They also looked at before and after the commercial release of stent grafting, and they also broke it down to a learning curve and after the learning curve was over. This is a superb study, and I urge all of you to read it closely. Circulation December last year. As you would expect, both for ruptured and intact thoracic aortic aneurysms, there was a lower mortality with TEVAR. But note that there was no statistically significant lower mortality for the intact aneurysms, as shown on your right. Well, what happened to 5 years? Above, on the top panel, is all patients. I hope you can see that. The upper curves are for intact aneurysms, the lower curves for ruptured. For ruptured, yes, there's a major advantage to TEVAR acutely, but by 2 years, you've lost any advantage, and the majority of patients are dead. Just for the intact aneurysms, as shown above, you'll note that at 5 years, the survival rate is superior for those who underwent open surgical repair, considerably superior. In the bottom left, you see the adjusted survival rates, and again you see TEVAR emerge as offering a lower survival expectancy compared to open surgical graft replacement. For the propensity matched pairs on the bottom right, this was also evident. TEVAR is associated with a poor 5-year prognosis and life expectancy, even when matched for the lowest risk quartile. So yes, more and more sicker patients are receiving TEVAR over time. Therefore, the surgical graft mortality rate would probably go down because we're not dealing with those desperately ill patients. But the proof of the pudding at 5 years does not support TEVAR. The point this paper made was that patients were receiving TEVAR who will not benefit, probably due to their comorbidities. This is not an isolated example. An excellent analogy is with what's going on today with percutaneous aortic valve replacement, or TAVR. In the partner trial, we've tried to define these cohort C patients, as Mike Mack pointed out yesterday, which is the invisible line between utility and futility. Yes, they have critical aortic stenosis. Yes, they're symptomatic, but they're dying of other things, not their aortic stenosis. Well, how do we define medical futility? The medical ethicists have done so this way. In judging futility, physicians must distinguish between an effect, which is limited to some part of the patient's body, and a benefit, which appreciably improves the patient as a whole, person as a whole. For the percutaneous aortic valve replacements, we look at it as a spectrum of STS operative risk score. On the bottom, if they're low or moderate risk, percutaneous AVR is irrational, reckless, financially irresponsible, and I could put a lot of other pejorative words there too. For the high or intermediate risk and the inoperables, it's reasonable. And then we have this invisible line to the far right where it really is futile. What's the future of TEVAR? Number one, we need randomized controlled trials still, despite the commercial availability of these devices, for specific patient substrates. The FDA is now formulating what they call PASs, post-approval studies, for any new device introduced on the market for one indication. For example, thoracic stent grafts for acute aortic dissection. We all know these will be used in many, many other indications, but the manufacturer will have their labeling in jeopardy if they do not conduct these rigorous PASs, which are equivalent to phase 4 monitoring in the old jargon. They're almost as rigorous when it comes to data collection as are the randomized trials. So it's expensive, it's time-consuming, but the FDA is going to mandate this in their next approval steps, and certainly for thoracic aortic stent grafts. Where we really need more randomized trials, where there's certainly equipoise between what's best, is what you see on the bottom. The chronic A or type B false aneurysm involving the descending aorta. There are numerous reports of treating these patients with TEVAR, numerous reports of treating them surgically, but we really don't know what is best. Hopefully, the Cardiothoracic Surgical Networks trial, which just got refunded by NIH, will sponsor this randomized trial starting this year or next. Patient selection must be critically re-examined. Regulatory oversight is coming, looking at cumulative cost effectiveness, cumulative radiation exposure, and quality-adjusted life year gains. And continuing reimbursement may be predicated upon meeting certain outcome metrics, just like they're doing with the national coverage decision, they meaning Medicare, CMS, is doing with the national coverage decision for TAVR, percutaneous aortic valve, and that final document will be released next week. If you don't meet certain outcome standards, your hospital and you will not be reimbursed in the future. This puts the responsibility squarely on the physician's shoulders to select your patients properly. And finally, I think physicians have to have the courage not to treat. In the United States, this is tough because if you say no, they'll go down the street and someone else will gladly do it. The key decision is whether or not any intervention is necessary and justified. We have to work together with our colleagues in vascular surgery, interventional cardiology, interventional radiology, trying to arrive at a decision what is best for that patient, if anything. If treatment is indicated, then you conjointly choose what is best. It's been an exciting 20-year journey. It's not over. There's unplowed ground ahead. There's a lot of uncertainty. There are a lot of unknowns. And despite Dr. Griep's admonition in 1998, TEVAR is here to stay. We just have to learn how to apply it more intelligently. Thank you.